Welcome to the Hospital Medicine Unplugged podcast.
Today we are diving deep into a topic that every single hospitalist faces.
Oh, absolutely. And it's almost always under intense pressure, right? It's typically during off hours or, you get that page on night call.
Exactly. We're talking about discharge against medical advice, or AMA.
And this is so much more than just an administrative hurdle or, a difficult conversation.
It really is. This is a moment of critical, ethical, clinical, and of course, legal risk.
Understanding how to navigate it with precision and compassion is just essential knowledge.
Yeah.
I mean, for optimizing patient safety and, frankly, for protecting ourselves.
It's truly one of the most serious decisions we confront in the inpatient setting. The stakes are just so incredibly high.
Yeah.
When a patient decides to prematurely terminate their hospitalization, before the medical team thinks it's safe or appropriate, we enter this high-risk zone where the usual safety net is just gone. So our deep dive today is really focused on synthesizing the evidence around this event and maybe more importantly, giving you a structured, actionable approach.
And the goal is really twofold here.
That's right. First, to reduce AMA rates by getting at the underlying drivers, and second, to mitigate the significant clinical and legal risks involved.
So that even when a patient insists on leaving, we know we've provided the best possible harm-reducing care backed up by just meticulous documentation.
Exactly.
And the scale of this problem is, frankly, much larger than I think many of us realize. This is not a rare occurrence that just impacts, one or two outlier institutions.
Not at all. AMA discharges account for approximately 1% to 2% of all hospital discharges in the U.S. annually.
And while 1% might sound small on the surface,
well, when you extrapolate that across the entire healthcare system, the numbers become staggering.
They really do. There was data from 2002 to 2011 that showed over 338,000 hospitalizations every single year ended in an AMA discharge.
338,000. That's nearly 1/3 patients a year leaving early.
It's unbelievable.
And here's where it gets really interesting, I think. The rates are incredibly variable.
Right.
Depending on the institution you're at, the prevalence can range wildly. Sometimes from less than 0.5% all the way up to 12.5%.
Wow, that is a huge range.
It's immense, and that range suggests that this isn't purely a reflection of some immutable patient characteristic.
No, it can't be.
It's a reflection of structural and system factors that we as hospital leaders and clinicians can and frankly must influence.
That's the key point. If one hospital can manage a 1% rate and another is dealing with 10%, the difference has to lie in the processes, the resources, and the culture of care.
Absolutely.
That structural perspective is so important. Our mission today is to go beyond, this simple clinical checklist and really analyze the clinical, ethical, and legal dimensions of this.
Because if we can better identify why patients are leaving, we can implement targeted system strategies to intervene early.
Right. But before we get to the solutions, let's start with the cold, hard data on what happens after a patient signs out AMA. Because the consequences are, in a word, devastating.
The outcomes are sobering. They really demand our attention. The primary concern is the severity of subsequent morbidity and mortality.
This is the bottom line.
It is. AMA discharge is consistently associated with a 2 to 2.5-fold increased odds of overall mortality.
So you're basically doubling your risk of dying.
Essentially, yes. When studies rigorously adjust for confounding factors, things like existing illness burden or comorbidities, the adjusted odds ratio for death still ranges from about 2.05 to 2.46.
That magnitude of risk is shocking. But there's a clinical paradox in the data that I think is important to clarify, especially for our colleagues who might be newer to this literature.
Okay.
If you look at just the 30-day in-hospital mortality, it's actually lower for AMA patients. It's around 2.5% versus 5.6% for routine discharge. So why do we see that immediate in-hospital benefit only to have the long-term mortality risk just explode?
That is a critical nuance, and it highlights a deeply troubling reality. These patients are often simply relocating the site of their death. They're more likely to die outside the protected, monitored environment of the hospital, and often within days or weeks of leaving.
So the premature termination of care combined with all the post-discharge barriers.
Exactly. Things like homelessness, profound financial strain, or just the lack of social support to manage their acute medical needs. All of that drives this massive increase in community mortality.
Right.
The data shows this elevated mortality risk that true twofold increase is evident within just 1 week of discharge, and it persists robustly for at least 180 days.
180 days, that's 6 months.
6 months.
6 months of persistent doubled vulnerability. That absolutely reframes AMA. It's not an acute one-time event.
Yeah.
It's an ongoing systemic failure that establishes a trajectory of severe long-term harm.
That's a great way to put it.
And that vulnerability, it immediately translates into a clinical and financial burden through readmissions.
Yeah.
It often hits the system twice.
Precisely. The data on readmissions really mirrors the mortality figures. Patients discharged AMA have twice the odds of 30-day all-cause readmission compared to routine discharge.
And the rates.
The rates consistently hover around 21% versus about 11.9%. The adjusted odds ratio for readmission is reliably found to be around 2.0 to 2.06.
Again, double the risk.
Double the risk. But the timing is maybe the most damning part of this readmission cycle.
They come back sooner.
Much sooner. A shocking 19.0% of AMA-related readmissions occur within the first day after discharge.
The first day.
The first day. Compare that to only 6.1% for non-AMA patients. This strongly suggests that nearly 1/5 of AMA patients are leaving in a state of clinical instability that just deteriorates almost immediately.
And the studies also show that when they're readmitted, they're often not coming back to us.
That's right.
Patients discharged AMA are significantly more likely to be readmitted to a different hospital, something like 43% of the time, compared to about 24% for non-AMA patients.
That's a nearly 20-point difference.
And that tells us something profound about the patient-provider relationship, or maybe the lack of one. During that initial stay, it just signals a complete erosion of trust.
It absolutely suggests a profound breakdown in the therapeutic alliance. You know, they may perceive the care as substandard, they may feel judged, or they may simply want to avoid the location where they experienced the friction that led to the AMA event in the first place.
And that avoidance just fuels the readmission cycle.
Which is extremely costly to the entire healthcare system. The economic impact is staggering. In 2014 alone, AMA-related readmissions consumed over 400,000 inpatient hospital days nationwide.
400,000 days. And the cost?
Over $800 million.
$800 million for potentially preventable readmissions stemming directly from a premature discharge. That's not just a clinical failure. It's a massive drag on hospital resources and quality metrics.
It is.
It just underscores that intervening early to prevent an AMA event isn't just ethical, it's financially prudent. It's essential for system sustainability.
And we know these risks are directly attributable to the incomplete treatment. If you look at the logistics, AMA patients have a significantly shorter length of stay.
How much shorter?
On average, about 3.37 days versus 4.16 days for matched planned discharges.
So they just aren't staying long enough for us to stabilize their acute illness or to adequately plan for their complex post-discharge needs.
That's it. The increase in risk is a direct result of that truncated care timeline.
And the types of conditions that bring them back often just scream incomplete care, tied to things like socioeconomic vulnerability or addiction.
Correct. The most frequent causes of readmission after an AMA discharge are often complex and intertwined with chronic conditions or substance use.
What are the top culprits?
Well, the top ones include alcohol-related disorders, which account for 9% of readmissions, also substance-related disorders more broadly, skin and subcutaneous tissue infections.
Which are often linked to IV drug use or homelessness.
Exactly. And also non-diabetic pancreatic disease. These are conditions that absolutely require continuity, robust social support, and often long-term addiction treatment.
None of which is adequately addressed by a 3.37-day inpatient stay that ends in an AMA refusal.
Not at all.
That data gives us a really clear picture of who is returning, when they are returning, and why the risks are so incredibly high. So let's shift our focus to actionable identification. This brings us to the next phase of our deep dive. Identifying and understanding high-risk predictors.
Good.
If we can identify these patients early, we gain that crucial time needed to intervene and, potentially prevent the AMA event entirely.
And the demographic profile of AMA patients is remarkably consistent across institutions and studies, which offers us a strong signal.
Okay, so who are we looking for?
They're significantly younger. The mean age is about 47.1 years compared to 56.5 years for a routine discharge.
47, that's young.
It is. In fact, if we look at age stratification, patients aged 30 to 35 years old have the single highest rate of AMA discharge at 16%.
And this younger demographic often carries different life priorities than older patients, right? They might have jobs they're afraid of losing, childcare issues, or just other responsibilities that feel more urgent than a hospitalization they perceive as slow or inefficient.
Exactly. And compounding this, we see a strong gender association. Male sex is consistently documented, representing 61 to 63% of AMA discharges.
And the odds ratio.
It ranges from 2.0 to 2.40. Furthermore, these patients frequently lack established social supports. They're often documented as living alone or lacking an established primary care physician.
Which just eliminates that essential safety net of ambulatory follow-up.
Completely.
But if we want to talk about the truly powerful predictors, the ones that force us to look critically at systemic failures, we have to look at socioeconomic factors. This is where that structural competency framework becomes so essential, forcing us to ask how poverty and institutional neglect are influencing clinical decisions.
The data is just crystal clear on this. Socioeconomic disadvantage is a powerful driver. The strongest independent predictor of AMA discharge isn't clinical at all.
What is it?
It's the lack of health insurance, which is associated with an astounding adjusted odds ratio of 3.78.
A nearly four-fold increased risk just from lacking a reliable payer source. I mean, given that, do we risk creating a situation where we're penalizing providers for a problem that is fundamentally political and socioeconomic, not clinical? We're asking hospitalists to overcome systemic hurdles that should have been solved years ago.
That is the core conflict. Nearly 40% of AMA patients are in the lowest income quartile, and 55% overall have Medicaid or are uninsured.
So they fear the bill.
They fear the bill, they fear the economic fallout of prolonged absence from work, they fear losing benefits. Our medical advice is often competing directly with their basic survival needs.
And the most stark indicator of that social vulnerability is homelessness.
Yes, which is associated with a 6.2-fold increased odds of AMA discharge. When a patient is homeless, leaving the hospital may be driven by the need to secure a shelter bed, check on their possessions, or access necessary social services that are only available outside the hospital walls.
So if we don't address that competing priority, the need for housing or financial security, no amount of medical education about their STEMI or their DKA is going to keep them in that bed.
That's right.
Now let's look at the clinical and behavioral drivers within the hospital, which often overlap with these socioeconomic issues.
The clinical drivers are overwhelmingly dominated by mental health and substance use comorbidities.
That's surprising.
Mental health disorders represent the single largest diagnostic category associated with AMA discharge, indicating profound psychological distress and often a lack of adequate long-term psychiatric care.
And specifically within that,
Alcohol and drug abuse disorders are the most powerful specific clinical predictors. They carry an odds ratio of 5.2 for substance use disorders specifically.
so this is a population struggling with complex dual or multiple diagnoses, where withdrawal symptoms or just the preoccupation with obtaining substances becomes an overwhelming driver to leave.
Absolutely.
And if we look for the single most predictive factor of all, it dramatically outweighs all the others, including lack of insurance or even homelessness. It's their history.
The strength of this predictor just cannot be overstated. The strongest predictor of a subsequent AMA discharge is a prior history of having left AMA.
And the odds ratio is?
It's a staggering 170.
170, that number isn't a measure of biological risk. It's a measure of accumulated systemic failure and mistrust.
It is.
It tells us that once that cycle of negative interaction, incomplete treatment, and judgment is established, once they burn that bridge of trust with the healthcare system, it becomes incredibly difficult, almost impossible, to convince them to return or complete care.
That's exactly right.
This history just reinforces that we're dealing with chronic, deep-seated system avoidance.
Exactly. It mandates that when we see that history flag in the chart, we activate our highest level of intervention immediately, focusing entirely on building trust and addressing their specific unmet needs.
Okay, so we've established the profile and the severity of the problem. Now let's shift to the systems role, because these are factors that are potentially modifiable by us. Where are we, as healthcare providers and institutions, failing to meet the patient?
Well, a significant and often cited driver is poor communication and unmet patient expectations.
Tell me more about that.
Patients who perceive poor communication, who feel they weren't properly oriented to the logistics or expectations of hospitalization, or who just failed to establish a supportive provider-patient relationship, are far more likely to leave.
It's not just about delivering data, it's about the emotional quality of the interaction.
Absolutely. Stigma, for instance, is a massive driver. Negative interactions, inadequate pain or withdrawal management, feeling judged by staff, or seeing stigmatizing documentation in their chart. All of that contributes substantially to their decision to self-discharge.
That idea of stigmatizing documentation is deeply unsettling. It means that our own clinical records, which are intended to communicate objective reality, can become part of the problem.
They can.
They confirm the patient's perception of judgment, and they make them feel unwelcome or misunderstood.
That is precisely what happens. The notes can often reflect an adversarial relationship. We also see clear temporal factors at play, which point to resource allocation issues.
Like what?
Emergency admission, especially arrival by ambulance, is associated with higher AMA rates, likely due to the initial chaos and lack of control.
Okay.
Evening and night shifts, when staffing might be leaner, and support services like social work or case management are harder to access, are associated with higher rates.
Right.
And specifically for alcohol withdrawal patients, weekend discharges are a clear risk factor, potentially because follow-up treatment centers are closed or coordination is delayed.
So if we're looking for the most critical, modifiable clinical factor we can immediately address in the patient's room, what's the target?
It centers squarely on aggressive symptom management. Undertreated pain or withdrawal symptoms are consistently identified as critical modifiable factors.
Give me some evidence for that.
Okay, consider this compelling evidence. Methadone use during hospitalization was found to be protective against AMA discharge.
So that's not just a correlation.
No, it demonstrates that effectively managing opioid withdrawal symptoms significantly reduces the psychological and physical distress driving the patient to leave. It improves their tolerance for hospitalization and allows them to complete necessary care.
So addressing pain and withdrawal is perhaps our most direct, immediate, and effective lever to reduce AMA discharges.
I believe it is.
That brings us perfectly to the bedrock of this whole issue.
Yeah.
Ethics. We are dealing with a scenario where a patient, an autonomous adult, has the right to refuse care, even if that refusal might lead to severe harm or death.
It's a true conflict.
We must dedicate significant time now to the ethical framework and capacity assessment.
The core ethical conflict is that struggle between respecting patient autonomy, the right to self-determination, and fulfilling our duty of beneficence and non-maleficence.
To do good and avoid harm.
Exactly. Competent adults have a fundamental legal and ethical right to refuse treatment. Our goal is never to override that autonomy through coercion,
Right.
but rather to ensure that the patient exercising that right has the capacity and the comprehensive information necessary to make a truly informed choice.
Before we delve into the assessment itself, we have to clarify two terms that are frequently misused interchangeably in the clinical setting: capacity versus competence.
This distinction is absolutely fundamental to risk mitigation. Capacity is a clinical determination.
Right, something we do at the bedside.
Exactly. It is decision-specific, it can be temporary, and it's assessed by the treating physician or the clinical team. You know, if a patient is delirious, they lack capacity for this specific decision at this specific time.
And competence.
Competence is a legal determination made only by a court of law. As clinicians, we assess capacity. We do not determine competence. Our entire ethical approach to navigating an AMA request rests on a meticulous, structured capacity assessment.
And this is where we have to move away from, a subjective gut feeling or a simple mental checklist. We need to rely on the established, structured criteria.
We do. We rely on the 4 pillars of capacity described by Applebaum and Griso.
And those 4 criteria provide a systematic roadmap that has to be formally assessed and, just as importantly, documented in the note.
That's right. The first is understanding. Can the patient comprehend the relevant medical information? This includes their diagnosis, the nature of the proposed treatment, and any alternatives.
Okay, that's straightforward.
The second pillar is appreciation. Can the patient recognize the nature of their own situation and the likely personal consequences of the choice they're making?
That distinction between understanding and appreciation is where I think many clinicians struggle. Maybe we could use a quick example.
Certainly. Imagine a patient admitted with severe sepsis who is refusing IV fluids and antibiotics because they feel fine.
Okay.
They may understand that sepsis is a dangerous systemic infection that requires IV treatment. That's the first pillar, understanding.
They can repeat the facts back to you.
But they may fail to appreciate that they themselves are gravely ill and face imminent organ failure if they leave. This is often because of denial or anxiety or just a distorted perception of reality due to their illness. Appreciation links the general medical facts to the patient's unique personal circumstances.
That's a great clarification. What are the final 2 pillars?
The third is reasoning. Can the patient compare the risks and benefits of the options available to them using a logical, rational process that's consistent with their stated values?
And the fourth?
And finally, communication of choice. Can the patient clearly and consistently express their decision, which has to align with their stated reasoning? If they keep changing their mind or can't articulate why they are choosing to leave, the assessment is incomplete.
And before we can conclude a patient lacks capacity and, move toward protective measures, we have an ethical duty to optimize their capacity by removing all reversible barriers first.
This step is so essential and so often overlooked in the rush of an AMA event. We should be aggressively treating reversible conditions like metabolic delirium or poorly controlled pain or acute withdrawal symptoms before we make the determination that a patient can't make decisions.
So if a patient is in acute alcohol withdrawal, we need to treat them, wait for the withdrawal to resolve, and then reassess their capacity.
Precisely.
And addressing communication barriers is also vital to prevent creating a situation we can resolve ourselves.
Absolutely. If we explain things poorly, if we use excessive medical jargon, or fail to translate complex concepts, or just overwhelm the patient with information, we risk creating what's known as pseudo-incapacity.
Pseudo-incapacity.
The patient appears unable to process the information, but the deficit is actually in our delivery, not in their cognition. We have to simplify the information, use visual aids, and ensure our language is accessible.
And we must always remember that capacity is fluid. It's evanescent and decision-specific. A patient might have capacity one moment when they're calm in the morning and lose it the next when they're acutely agitated or withdrawing at night.
This necessitates serial reassessment. We have to continually check capacity, particularly when a patient's condition changes or when the decision they face carries dramatically different consequences.
So we should try to delay an important decision until a period of greater lucidity if we can.
If at all possible, yes. Wait until their pain is controlled or their delirium is partially resolved. We should prioritize that stabilization.
So when we've done our best to optimize capacity and the patient with capacity still says, "I'm leaving," how do we bring all this structured thinking into a real-time, high-stakes encounter? The literature strongly advocates for the AIMED framework.
The AIMED framework is your systematic, ethical, and legal roadmap for navigating the AMA event. It shifts the focus from just getting a signature to providing comprehensive risk mitigation.
Okay, let's break down that acronym into clinician actions. What's A?
First, assess decision-making capacity and clinical risk. Use those 4 pillars and explicitly calculate how unstable the patient is. This dictates the urgency of your intervention.
Hang on.
Second, investigate the underlying reasons for leaving. This moves us away from judgment. Ask open-ended, non-leading questions like, what is the single most urgent thing you need to take care of outside the hospital right now?
Are they worried about their dog, their job, their untreated pain?
Exactly. Third, mitigate modifiable factors. This is where we act. Can social work arrange transportation or contact a relative? Can we provide a dose of pain medication or IV fluids right now? Addressing the reason they want to leave is often the best way to keep them. Fourth, explain risks in a patient-centered, truthful manner. Frame it as, if you leave now, you risk X, Y, and Z, which could lead to severe harm or death, not as some kind of punitive threat.
And finally, D.
And fifth, document all assessments and interventions thoroughly. The quality and detail of this narrative note is your ultimate legal defense.
The AIMED framework really shifts the focus from get the form signed to provide the highest possible quality of harm-reducing care under inherently difficult circumstances. Let's move to the practical application in the room, focusing on managing the negotiation and communication.
The goal here, as we mentioned, is respectful negotiation, not coercion. We have to enter this conversation with the mindset that while we, the physicians, are the experts on medicine, the patient is the undisputed expert on themselves.
Their values, their priorities, their unique life circumstances.
All of it. The purpose of this negotiation isn't to force compliance, but to understand the patient's concerns and reach a mutually acceptable, harm-reducing decision.
That distinction, negotiation versus coercion, is where many new hospitalists fail, I think. They often default to a paternalistic style when they feel anxious about the patient's risk.
They do.
So how do we approach that conversation effectively when emotions are running high on both sides?
Structured communication models are just non-negotiable here. The foundation is active listening, empathy, and validation of the patient's concerns.
So if a patient says, "I feel trapped here and my withdrawal symptoms are unbearable," what's our first response?
Our first response should be to validate that distress. I hear you, and I understand this must be extremely difficult and uncomfortable for you. Avoid that adversarial language completely. Immediately launching into the risks of their sepsis only reinforces the perception that we don't care about their discomfort.
Right. For clinicians dealing with high-stress, potentially aggressive situations, the literature specifically mentions the CALMER framework for teaching de-escalation skills.
Yeah.
What does CALMER emphasize for the clinician?
CALMER is primarily about clinician self-regulation, ensuring that we don't escalate the situation by accident. It focuses on acknowledging control limits and altering one's thoughts about the situation.
Can you give an example?
Sure. A technique like naming it to tame. It helps clinicians recognize the strong emotions they're feeling, fear, frustration, anger, so they can manage them internally and remain non-reactive. It teaches us to tolerate uncertainty and ambiguity, which are endemic to these situations, that self-control is necessary to maintain empathy and keep the conversation productive.
And we can also apply motivational interviewing, or MI, as a powerful, non-judgmental tool to move the patient toward change.
MI is invaluable because it fosters patient ownership and leverages their own motivations. Instead of telling them they must say because the DKA will kill you, we use open-ended questions to explore ambivalence.
So something like,
what are the benefits of leaving right now, and what are the benefits of staying just one more day to stabilize your sugar? This helps them articulate the cognitive dissonance between their immediate desire to leave and their ultimate long-term therapeutic goals. It fosters a true commitment to care.
Now, we have to address the most difficult scenario. What if the assessment, despite our best efforts to optimize capacity, clearly shows the patient lacks capacity and is medically unstable?
This is the strict dividing line between an AMA discharge and involuntary commitment. If the patient lacks capacity, meaning they fail one or more of the 4 pillars, and they meet the legal criteria for involuntary hospitalization.
Meaning they pose an imminent medical risk to themselves or others.
Right, due to their inability to make rational decisions, then commitment is required. We cannot ethically or legally permit an AMA discharge for a patient who is actively psychotic, severely delirious, or profoundly hypoglycemic with a life-threatening illness.
And in that rare circumstance, the documentation must be ironclad. It has to support both the imminent medical risk and the capacity deficit based on those 4 criteria.
Absolutely. You have to specifically state which of the Applebaum and Griso criteria they failed and why, linking it directly to the immediate danger posed by their medical condition.
However, as we noted, in the vast majority of AMA events, the patient retains capacity and simply insists on leaving. This is where harm reduction becomes paramount.
It does.
Since we can't complete the ideal treatment, we have to negotiate the safest possible departure, maximizing what the patient will accept.
That is the ultimate goal. Reducing harm, one action at a time. This involves offering partial treatment, maybe an IV fluid bolus, some specific diagnostics, or a dose of antibiotics or pain medication before they walk out.
And prescriptions.
We must provide provisional prescriptions for essential chronic medications like antihypertensives or insulin. And critically, for patients with opioid use disorder, this means dispensing naloxone and ensuring they have sufficient medication for withdrawal or pain management for the next 24 to 72 hours.
And this is also the moment where we have to try to connect them with the outside world, regardless of how futile it feels in the moment.
Yes. We have to proactively schedule urgent follow-up appointments, even if the patient expresses reluctance to attend. We should try to contact their next of kin or emergency contact.
But only with the patient's explicit permission.
Of course. Only with permission to inform them of the situation and the immediate risks. If they refuse contact, that refusal must be documented, which demonstrates that we attempted to establish a safety net.
And when delivering this final critical information, whether it's the risks of leaving with a STEMI or the instructions for their provisional prescription, we need to be clear and concise.
Focus on delivering 3 to 5 key actionable messages delivered in simple everyday language. And most importantly, use the teach-back method to confirm comprehension, even if the patient is agitated or clearly reluctant.
So you have to ask them to reiterate the information in their own words.
You do. I know you are anxious to leave, but just to make sure I explain everything clearly, can you tell me what you need to do immediately if your breathing gets worse at home? This confirms that the patient understood the risks and instructions, which is vital for both their safety and our legal defense. It proves the informed part of the AMA decision.
That emphasis on the teach-back method really drives home the quality of care metric. Okay, moving on. Let's detail the evidence-based system-level interventions that can proactively prevent AMA events, particularly in our high-risk substance use disorder population. We need to standardize our processes.
Standardizing and individualizing our discharge process is the first step away from reliance on rushed checkbox discharges. The IDEAL discharge planning strategy is an excellent evidence-based framework that moves beyond the typical rushed physician-centric discharge.
It ensures critical communication points are met. And what does IDEAL represent?
Involve patients and families as full partners in the discharge discussion. Discuss key areas to prevent problems at home, like potential complications, wound care, or medication issues. Educate about the condition and the full discharge process. Assess understanding using Teach Back Again, checking for comprehension. And listen to patient goals and preferences, integrating their priorities into the plan. A comprehensive, patient-centered discharge plan directly addresses many of the communication failures and unmet expectation factors that drive AMA discharges in the first place.
This requires a massive commitment of time and resources, which contrasts sharply with the typical high-volume pressure hospitalists face. But we know that investment pays dividends, especially when addressing the highest clinical risk factors.
Absolutely. And the intervention with perhaps the most striking, game-changing data is related to substance use disorder management. We need to talk extensively about the impact of medications for opioid use disorder, or MOUD.
The evidence for MOUD initiation is incredibly compelling for reducing AMA events.
The data is extremely strong. Early initiation of MOUD, so buprenorphine, methadone, or naltrexone during hospitalization is strongly associated with a reduced risk of AMA discharge.
What's the odds ratio?
The adjusted odds ratio is 0.73, which translates to a substantial 27% lower risk compared to patients who received no withdrawal treatment whatsoever.
That's a huge effect.
It is, and what's even more telling is that receiving adjunctive non-MOUD withdrawal treatment alone, like clonidine, was associated with a higher risk of patient-directed discharge.
Really?
Yes. This suggests MOUD provides a unique, superior protective effect by addressing the underlying neurobiology of the addiction and withdrawal.
And the positive outcomes extend far beyond the hospital stay, which confirms that we are not just masking symptoms. We are initiating a successful path to chronic disease management.
That is correct. MOUD provides continuity. Patients discharged with ongoing MOUD had substantially lower 30-day all-cause readmissions.
How much lower?
18.8% versus a staggering 35.1% for those discharged without MOUD.
Wow.
This massive difference is a direct result of linking the patient to therapeutic community-based care that mitigates their highest risk factor. It saves lives and dramatically cuts costs.
This powerful data points directly to the necessity of dedicated, specialized resources, specifically addiction consult services.
Addiction Consult Services, or ACS, significantly improve outcomes across the board by integrating expertise directly into the acute care setting. Data from studies like the CATCH trial show that patients discharged from hospitals using ACS had nearly 8 times higher odds of MOUD initiation during the hospitalization.
8 times.
And almost 7 times higher odds of 30-day MOUD engagement compared to those without the service.
That is a phenomenal impact. It suggests ACS acts as a force multiplier for a high-impact clinical intervention. What specifically do these services provide that the average hospitalist, juggling 10 other issues, just cannot?
They provide holistic expert care. This includes definitive addiction diagnosis, crucial counseling and psychoeducation, timely MOUD initiation and dose adjustment, and most importantly, a warm handoff and crucial linkage to post-discharge care.
So they bridge that gap.
They bridge the gap between acute medical needs and chronic addiction management, ensuring the patient does not leave the hospital, even AMA, without a plan to manage their most powerful clinical driver, their substance use disorder.
Of course, MOUD implementation requires thoughtful logistical coordination, especially considering the regulatory hurdles associated with methadone and buprenorphine.
This is a critical point that hospitalists must proactively manage. For methadone, coordination with OTPs or opioid treatment programs is essential.
Methadone is heavily regulated.
It is, but hospitals need to establish clear, rapid processes to dispense up to 72 hours of take-home methadone at discharge as a bridge to community treatment. This prevents immediate catastrophic withdrawal while the patient enrolls in the OTP.
And for buprenorphine?
The process is often simpler but equally vital. Ensure the patient leaves with enough medication, often a supply of 4 to 7 days, to last until their first follow-up visit with an established ambulatory prescriber. It prevents them from running out during that transitional period.
And finally, we have to address the longitudinal need. Given the persistent mortality and readmission risks extending 180 days out, post-discharge continuity can't just end the moment they walk out the door.
We need to employ proactive, aggressive outreach models. This includes peer navigation services where someone with lived experience connects with the patient, transitional care management programs which offer intensive follow-up coordination, and specialized bridge clinics that serve as a rapid access lifeline.
And these specialized services are designed to provide that intensive support during the immediate, high-risk post-discharge period.
That's right. They help AMA patients, who often face compounding disadvantages like homelessness or lack of insurance, stay connected to care long enough to stabilize their lives.
We've established that the patient's clinical and social well-being is the primary goal, but we must also explicitly acknowledge the necessary legal dimension. For the final part of our deep dive, we need to focus on the art and defense of documentation.
This is where clinical practice translates directly into legal self-defense. It is a critical misconception that a signed AMA form alone provides legal immunity.
It does not.
It does not. In fact, a signed form that isn't supported by a detailed narrative note is often legally worthless. The successful legal defense hinges entirely on whether your detailed documentation supports two critical underlying assumptions.
Which are the benchmarks for clinical diligence?
First, that the patient was fully informed and had the decision-making capacity to make that choice. And second, that the high-quality care you provided up to the point of discharge met the contemporary clinical standard of care.
If you can't prove those two things in the chart, the signed form is meaningless in court.
Precisely.
So we need to go far beyond the checklist on the form and write a comprehensive narrative note that explains the entire process. What are the essential elements that must be included, demonstrating that AIMED approach?
We have to document the AIMED process in minute detail, creating a bulletproof record of our diligence. Specifically, first, a detailed assessment of capacity, explicitly addressing all four Applebaum and Grissow criteria.
So you have to say something like, patient demonstrated capacity to understand diagnosis of STEMI and appreciated the risk of sudden cardiac death if they leave, but chose to prioritize securing housing.
Exactly like that. Second, the specific risks explained based on their diagnosis. This needs to be tailored, not generic. For a patient leaving with DKA, you must document the risk of cerebral edema, severe acidosis, and death. For a patient with sepsis, the risk of multi-organ failure and shock.
And use truthful, patient-centered language. No hyperbole, but no softening of the facts either.
Right. Third, the patient's stated reasons for leaving, ideally recorded verbatim using their own words. This shows you investigated the cause and tried to mitigate it.
What's next?
Fourth, all harm reduction measures offered. This includes provisional prescriptions, the exact type and dose of partial treatment accepted, like agreed to 1 liter of IV fluids, and documentation of urgent follow-up scheduling.
And
Fifth, multidisciplinary involvement. Document the conversations with social work, case management, psychiatry, or ethics, and note the specific systemic barriers they attempted to address. This proves you didn't act alone and tried to address the social determinants of health driving the decision.
You touched on this earlier, but it deserves robust emphasis here, as it relates directly to structural competency. The ethical imperative to avoid stigma in documentation.
This is an area where our profession needs to evolve rapidly. Qualitative analysis of AMA notes frequently finds language that reflects adversarial relationships and language that stigmatizes patients.
Using words or phrases that insinuate character flaws.
Exactly. Describing the patient as non-compliant or drug-seeking rather than detailing their clinical needs. This practice is dangerous, not only because it reflects poor patient-centered care and bias, but because that stigmatizing language can poison the well for future care providers.
So the documentation must be neutral, clinically relevant, and grounded in that structural competency framework.
Focusing on systemic barriers and clinical symptoms rather than individual failure or personal judgment. Yes.
The ultimate takeaway here seems to be that the best legal protection is not the form itself, but the consistent, demonstrable commitment to high-quality, compassionate care throughout the entire process.
That is precisely correct. The AMA form is merely a statutory acknowledgement of the refusal. Your defense is built on high-quality, patient-centered care, coupled with comprehensive contemporaneous narrative documentation of the AIMED process. That narrative note is the evidence of your ethical and clinical diligence.
This has been an incredibly detailed deep dive into one of the most high-stakes situations a hospitalist faces. We started with a harsh reality that AMA discharge doubles mortality risk and readmission rates, often leading to a profound breakdown in trust.
Evidenced by patients seeking care at a different facility.
Exactly. We moved through the patient profiles, younger, male, homeless, uninsured, with substance use being critical factors, and then anchored ourselves in the ethics of autonomy and formal capacity assessment using the 4 pillars.
And we identified the structural and modifiable clinical factors we can control. Communication quality, aggressive management of pain and withdrawal, noting the powerful protective effect of MOUD initiation, and the system leverage provided by addiction consult services.
The ultimate mission in these high-stakes encounters is harm reduction, guided by the AIMED framework, culminating in a detailed, non-judgmental narrative note that reflects the complexity of the patient's situation.
Right.
If we look back at the most compelling data point we discussed, it was that 43% of patients discharged to AMA are readmitted to a different hospital, which is nearly double the rate of routine discharges. This reflects profound institutional dissatisfaction and avoidance.
Indeed. And this raises an important and, I think, provocative question for us as hospitalists and system leaders. If high rates of AMA discharge and subsequent readmission to different facilities reflect a systemic breakdown in trust and perceived stigma, if we are failing to meet the patient where they are, focusing only on our medical agenda, how fundamentally must we change our institutional culture and financial incentives to ensure that the patient's perspective, their social needs, their withdrawal symptoms, their fear of judgment, becomes the primary metric for defining successful care completion rather than simply documenting the refusal?
That is the real structural challenge we must address to drop those AMA rates closer to zero.